All right, Chapter 35, Pediatric Emergencies. This is the longest chapter in the textbook. This will be a fairly lengthy discussion. Although pediatrics do not account for a large number of the patients that we see, generally the situations that we encounter pediatric emergencies are fairly critical. So it'll take a little time to kind of get through this chapter and discuss all the potential options here. So, objectives will be found on pages 876 and 877 in your textbook. There are quite a few of those for this chapter. A couple of multimedia slides, communicating with toddlers, which is maybe helpful. Caring and empathy as well, and then information about SIDS, which would be very beneficial to watch. So our core concepts that we'll cover are the anatomic and physiologic characteristics of children, how they differ from adults, psychological and personality characteristics of children from different ages, how to interact with pediatric patients and their supporters and caregivers, how to assess the pediatric patient, how to identify and treat special concerns with the ABCs, shock and potential hypothermia, how to assess and care for various pediatric medical emergencies, especially respiratory disorders, how to assess and care for various pediatric trauma emergencies, and then how to deal with issues of suspected child abuse and neglect, and as well as children with special needs. All right, so to kind of recap from many now months ago that we covered lifespan development, we talked about pediatric age categories. Remember that newborns and infants basically span the birth to 1 year time span. Technically, neonates, which is the medical term for newborn, neonate is within the first 30 days of life or the first month. And infants are technically from that first month through that first year. Toddler age group is roughly ages 1 to 3, preschool 3 to 6, school age 6 to 12, and adolescent 12 to 18. And note that these are generally accepted age ranges. Please think about differences in individual children. Some infants learn to crawl much sooner than others. Some are walking before their first birthday while others are not. Some school-age children may begin puberty earlier than age 11, 12, even before age 10. So everybody's a little bit different, but these are kind of the generally accepted age ranges. So some anatomic and physiologic differences. Infants and children differ from adults in psychology, anatomy, and physiology. And just to understand some of these differences can help you assess your younger patients. Namely, and we keep coming back to this one, and we've touched on this numerous times throughout the course, but children have proportionally larger heads. So, and those that are, and the structures involved with the head. So tongues are proportionately larger. The occiput on the back of the head is larger. However, everything else is proportionately smaller. So when we're talking things in the neck, such as your airway, those are smaller. Baby teeth or deciduous teeth, those can be knocked out and block the airway. We don't have as strong of muscles. We don't have as stiff of bones the younger you are. That head being so much heavier makes them top heavy, more likely to go off balance. So to review airway a little bit more, remember that there's a smaller nose and a mouth, but proportionately larger tongue within them. The trachea is narrower, and it is funnel-shaped or more conical than it is in the adult, who has really kind of a straight or cylindrical shaped trachea. The cricoid cartilage is less rigid and less developed in the small child, meaning that the airway has a greater capability to collapse without significant trauma. And then obviously being smaller, airway structures are more easily obstructed. Good example shown in the picture here of how the child with the larger occiput, their head pushes forward more, whereas the adult's head relaxes back, and you can see the significant angles that you're talking with a child's airway with no padding beneath the shoulders compared to that of the adult. The chest and the abdomen, less developed, more elastic in the young patients. Infants and children use their abdomen to breathe. They don't have the stiff ribs to lift and move outward to create the vacuum. So therefore they rely more on their diaphragm and their abdomen to move out of the way in order for them to breathe. And then the abdominal organs are much less protected than that of adults. Adults, through a number of years of school and whatever our continued activities are, we've built up abdominal muscles. And then probably a lot of us have added a layer of fat over the top of that, so we have a nice little protective layer to many of our abdominal organs. The reason why babies can't sit up from the get-go is they don't have the abdominal muscles to keep them up. So that's why they're much more prone to having injuries. And I mentioned before, the elastic bones of the ribs is simply because they have not calcified yet. Body surface area, larger in proportion to body mass. So when we talk about how much a child weighs and how much skin is involved with that body mass, there's a lot more skin. There's a lot more potential for there to be damage to the outside compared to the overall weight. They're much more prone to heat loss through their skin. They may not have as thick a hair. They may not have as much fat tissues in there that are giving them a bit of a insulative layer. And they are more vulnerable to hypothermia. All of their internal thermostats and whatnot have not fully developed yet to keep them easily able to maintain their body temperatures. So in comparison, blood volume wise, a 9-pound newborn, which I understand 9 pounds is on the bigger end of newborns, has approximately the blood volume of a regular soda can, whereas a 60-pound child around a 2-liter bottle, or 2 liters of fluid, blood, and then a 125-pound adult, a smaller adult, around 2 liters, larger males and whatnot, closer to, larger adults, period, closer to 3 liters. So comparatively, blood volume obviously significantly less at the child level. So some psychological and personality characteristics kind of go along with our infants and children. Newborns typically have minimal stranger anxiety. They don't typically have the issue with people they don't recognize. Now, the closer they get to toddler, the more they have that attachment. The younger infant follows movement fairly easily. Older infants are a little more active, starting to kind of get some personality. Don't want to be suffocated. Whereas we move on to toddlers, toddlers do not like to be touched or separated from their parents. Believe their illness might be punishment. Most of them don't like to be naked. They frighten easy. They may be able to understand more than they can actually let us know. They don't want suffocation. They don't want stuff on their face. they don't want to be restrained. That's the reason why some of them are such fabulous escape artists from their child seats. Preschool, the 3 to 6 year age group, they do not like to be touched or separated. They're modest and don't like their clothing removed. They believe that their illness may be punishment. They fear blood, pain, and permanent injury. They're starting to understand that concept now. They're curious, and they can be cooperative, and they don't want anything touching their face. School-age kids, 6 to 12, they generally cooperate fairly well but want to be heard. They fear pain, blood, disfigurement, and permanent injury, and they're fairly modest. And then adolescents, 12 and up, want to be treated as adults. They generally feel that they're indestructible, but still have fears about permanent injury and disfigurement. Vary in their emotional and physical development, depends on how comfortable they are with their body, and they are highly influenced by their peers. So what techniques could you use to attempt to assess a crying infant? Well, if we're going to assess crying infants, some of our best techniques are to approach from across the room slowly and note everything we can before we actually get up close to the child. Involve the parent or the caregiver as much as possible. And then if we have an infant that's able to hold things and look at things, it's possible for us to distract them somewhat by giving them something to hold on to or look at. So interacting with our pediatric patients. So identify yourself. They want to know who you are and what you're doing. They probably think that you're a police officer because that's what they're most familiar with, but let them know that you're there to help them. If there's not parents around, let them know that you're getting a hold of their parents. And if they have no life threats, continue just at a calm pace and evaluate. Do an assessment. Let the child have nearby toys or something that might console them. You can kneel down to that child's level. Getting down at the child's level helps eliminate a lot of those fears. Smile. Touch or hold the child's hand or foot. Don't use equipment without first explaining what you'll do with it. So I'm going to listen to your lungs. You want to touch this. You want to try it, so on and so forth. Let the child see your face. Stop occasionally to find out if the child understands. Do not lie to them. Don't tell them this isn't going to hurt if it's going to hurt. You can tell them it might hurt, but just for a moment, if that's the case. Remember to take a second to think about implied consent and implied consent with minors. If they have a life threat, you can treat and transport them without a parent or caregiver being present. If this is a non-life threat, we need to exhaust all of our efforts to try to get appropriate consent from the parent or guardian prior to us going ahead and taking them in. All right, so the adolescent patient. The adolescent patient in many ways wants to be treated like an adult. They may not give us the full story if their parents are around. There are certainly going to be awkward things for them to discuss, such as sex and drugs and whatnot. So it may be advantageous for us to separate them from their caregivers, at least for a few moments. Have your partner go interview the parents and caregivers outside the room in a different room, and then you interview the adolescent themselves and try to get the story from them. So that way they give you the full story. So don't delay your evaluation because they're embarrassed. But explain to them we just need to have all the truth here. They don't need to be embarrassed. Most of these things we're not going to have, these things are probably not going to be discussed with their parents, but it's things that's important for their continued well-being. There's your video on toddlers. All right, so supporting the parents or other caregivers. Remember that this is just as much an emergency to many of the parents as it is to the child, and it may even be more of an emergency. I have seen plenty of cases in which we had maybe a moderately sick child, the whole situation got made worse because you have a parent who is just hysterical and losing their mind, and that makes the situation worse. In those cases, it may be better to try to remove the hysterical parent and try to use the sane parent in order to assess and treat the child. Try to explain this to the parents as well. Look, we really have to have you keep it together for the child to do their best. For us to do the best job possible, we need you to cooperate. We need you to be the calming influence for your child. So screaming and crying and being angry, try to be reassuring. Try to discuss this with them and let them know that this is actually harming their child. And if certain cases, we may need to involve law enforcement. So if the parents are trying to interfere with the child, the natural reaction for them to try to protect their child from harm. But if we're able to communicate and talk with the parents, in many cases, they actually come out and work together with us. All right. Now also remember that not everybody fits in the standard Ward and June Cleaver household. So you may have a couple of mommies, you may have a couple of daddies, you may have step-parents, you may have foster parents, you may have grandparents that are raising, or aunts and uncles that are raising the children. But a lot of these same feelings can be carried out depending, based off of whatever style family unit they have. So best case scenario, we have a cooperative parent, and that parent helps us take care of their child. So, and it may be even more advantageous to have the mom try to hold the oxygen up there for the baby. It's very apparent that this is a critical situation here with the smiling little butterball of a baby there. So ask them to help. That's probably one of the biggest things, asking them to help. Don't forget to talk to your patient, though. All right, so assessing our pediatric patients. Patient assessment, we know, is the most important skill, the most important tool we have in our toolbox. And we have to be a little bit creative sometimes when we are assessing children. We kind of have to modify things a little bit. One of the ways that we do this is to use what's called the Pediatric Assessment Triangle, or often called the PAT, not point after touchdown. But the Pediatric Assessment Triangle is a three-component tool that we can use to do a quick, almost a doorway assessment. In fact, in most cases, it is a doorway assessment. We look at three major things, and this lets us know just how sick are we. So we're looking at appearance, work of breathing, and circulation to the skin. So these doorway assessments that we're doing, the first side of the triangle is appearance, and consider the mental status using A or V. So if they're alert or verbal, that's pretty appropriate. Of course, we would prefer alert, but sometimes we got a sleepy kid, and verbal is, they wake up fairly easily. Secondly, we have breathing, including airway. And is there any abnormal airway or breathing going on? Sounds, efforts, positions, retractions, seesaw, head bobs, those sorts of things. So how hard are they struggling to breathe? They're really working at it, obviously a bad thing. It's very easy, that's good. And then the last part of the triangle is circulation. And this is typically just looking at their skin color. Pink is good, of course. Anything else is not as good. So the more areas that we have dingers, the worse off they are. So if we have 1 out of 3, that's bad, but 3 out of 3, that's really bad. All right, so scene size up and safety in the pediatric population. When you're entering the scene, enter slowly, make observations, look around, collect some notes and clues. obviously your standard precautions. There are a certain number of childhood diseases in which adults certainly can catch. Some of us adults didn't have all the immunizations that certain kids get these days, and we could still catch some of the things that kids commonly would get. Sometimes your quick observations entering the scene give you the actual key information that you're going to need to move forward with your patient assessment and get that idea of what's going on. So our primary assessment, obviously, we get a lot of our primary assessment from our pediatric assessment triangle. So that helps a lot. Remember, it identifies and treats the life threats. And it's an essential component of all assessments. Remember, we're looking at things such as mental status, interaction with their environment, their emotional state, tone, body position. So, and when we take a look at a general impression of this little guy here, I don't think any of us are terribly concerned. He looks happy, he's walking, he probably dropped something on the ground there. It's not a terribly big deal. But for the most part, our general impression of this guy is, oh, all right, this is all good. And hopefully we're doing this from the doorway, because the closer we get to him, perhaps this little guy's going to be a little more frightened of what's going on. And then we can't get as accurate of an impression. Next part of our primary assessment is assessing the mental status. Again, using AVPU. Same as the adult: alert, verbal, painful, and unresponsive. And occasionally we have to stimulate them a little bit to try to get anything out of them. We're going to assess the airway, of course. We're going to look at the airway and consider whether or not it's open. Do we need to suction it? Do we need to remove anything that's in the airway? We're going to look at breathing, check is their mental status altered because of their breathing. We have flared nostrils, bluish or pale skin tones, stridor or grunting, so noises from the airway, respiratory rate greater than 40, 50, 60, depending on the age of the kid, retractions, where we see muscles between the ribs pulling back, wheezing, working hard to breathe, decreased muscle tone, where they're just basically working so hard to breathe they don't have energy for anything else, and then use of abdominal muscles. Moving to circulation, check things such as capillary refill. Where capillary refill should blanch out, should come back in less than 2 seconds. We're going to look for things such as their pulse. Do we get a pulse in their brachial artery, particularly if they're small, they're infants, or we may be able to get a radial pulse if they're a little older. Check for any severe bleeding and look at their skin tones. And we make a decision: are they a priority patient? Priority patients are those that give us a poor general impression, unresponsive, severe difficulties in breathing, uncontrolled bleeding, they're shocky, maybe they're in cardiac arrest. And then our secondary assessment for our pediatric. At times, only source of history may be doing some sort of an assessment, doing some sort of an exam. School or another place where medical records aren't kept, or there's nobody around that can give us any information. Hit by a car in the street, for example. In these cases, a lot of it we may have to ask modified, very simple questions. Have you ever gone to the hospital before? Do you take any medicine? Do you take pills every day? Do you take a puffer every day? We may have to really modify and bring down to scale our questioning. Most kids have no idea if they're allergic to things, at least younger kids. All right, physical exam. In many cases, they recommend from a physical exam standpoint that we actually start from the outside and work our way in. It helps gain a little trust. If we jump right to their head, we walk up, ask a couple quick questions, we start grabbing their head, that makes them very fearful. But if we can start from the outside edges and kind of gain a little trust from them, that a lot of times makes things a bit easier for us. So If there are no injuries, the patient can be held in the parent's lap. Protect that child's modesty. If you move a piece of clothing, put it back. Explain to the child what's going on. Don't apply any pressure to soft spots. Remember, they may have fontanelles or soft spots for up to 18 to 24 months of age, particularly the anterior fontanelle. But you certainly can just gently run a finger just across it to see if it's bulging or depressed. Meningitis and head trauma can cause it to bulge. Dehydration can cause it to sink. We're going to do some physical exam of the nose and the ears. We're typically looking for any drainage or any foreign bodies. Children are nose breathers, so keeping the nose clean makes it much easier for them to breathe. Booger bulbs are not just for babies. Neck. Very vulnerable to spinal cord injuries. They don't have well ossified vertebrae, not to mention they have that big heavy head on that weak little neck that whips around very easily. That proportionately larger head, of course, and then the muscles and the bones are much less developed. If we need to put in an airway, remember to size the airway appropriately from the corner of the mouth to the earlobe. Examination of the chest. Be alert for wheezes and other noises. Look for symmetry, bruising, any paradoxical motion or retractions. A lot of times you'll see retraction of either the sternum or in between the ribs themselves. Abdomen and pelvis. Note if it's rigid or distended or painful or tender. Abdominal injury can impede the movement of the diaphragm. Remember, they need that abdomen to move in and out, in and out, in and out for the diaphragm to move. So building up blood and whatnot in there really gives us issues. Pelvis, check for stability of the pelvic girdle. Not rocking the pelvis, we're just putting a little gentle pressure on just to see if there is any pain response in order for us to tell if there's maybe some fractures or whatnot. On the extremities, don't forget to check CSM. That's pulses or circulation, sensation, motor function. Check for distal pulses, check for capillary refill. So if you have a fracture, say on your forearm, you may check a brachial pulse and try a radial pulse. See if you've got circulation distal to the injury. Mental status, open airway, breathing, pulse, reassessment remains about the same. We redo the primary assessment and then we reassess any treatments that we've done along the way. Continue to monitor the skin colors and tones and vitals, and then of course your care. So special concerns in the pediatric care. So maintaining an open airway. Remember to align and open an airway. Head tilt, chin lift if there's no trauma. Jaw thrust with spinal mobilization if you suspect trauma. Suction is a good thing. Remember to taper it down to no more than 5 to 10 seconds. If you're assessing or if you're suctioning a small child, no more than 10 to 15 in an adult. Check for blockage of the airway by the tongue. They have that big giant tongue. Placing your oropharyngeal airway, you can use a tongue depressor, or in this case a popsicle stick, and just basically take it, hold the tongue in place, and then slip the airway in its normal curvature. Nasopharyngeal airway, it's really not any differently placed than it is in an adult. Just remember though that in most cases we don't have pediatric sized oral and nasal airways. Or, I'm sorry, nasal airways. We have pediatric sized orals, but not typically nasals. So for clearing an airway obstruction, identify whether partial versus complete. Complete, there is really no air movement or just very slight squeaks. That means things such as the Heimlich maneuver are going to be necessary. Partial, position of comfort, oxygen, and transport. Yes, they may have some airway obstruction, but some airway is better than no airway. So we're going to try to not mess with it until advanced care. So in the infant, here is the method of clearing an airway obstruction in an infant. So the back blows. We can also do chest thrusts. So it's usually 5 and 5 to clear that airway obstruction. This little kid looks like he's doing just fine without it. Supplemental oxygen and ventilations. Remember, if we're dealing with peds, they don't often like to have things on their face, so sometimes we use what's referred to as blow-by oxygen. And blow-by oxygen, we may either take a mask and pull the little flapper valve off the inside of it. We may take a piece of tubing like this. Earlier we saw a picture of a small child that had a little Dixie cup, and they had run the oxygen tubing up through the Dixie cup. It kind of serves as a mask to kind of funnel oxygen in their direction. And if you look on 903 in your text, way up at the top, there's a picture of a little girl in an ambulance cot with a blue teddy bear. There actually is a piece of oxygen tubing that's running into that teddy bear, and what you don't see is on the front side of the abdomen of that teddy bear, there's kind of a little mesh, and that's where the oxygen flows out. And so it's a form of a way you can provide some blow-by O2. If they're unconscious, this is not going to be an issue. We're going to be able to apply a mask or ventilate as necessary. So to appropriately size the mask, remember, if we're going to ventilate a child, it goes from basically between the brow down to the cleft of the chin. Sometimes we don't have the right size one, so we may have to like flip an adult mask upside down. That may help fit it. It may actually run across their eyes a bit, but it helps us make do. We should have masks appropriate for various sizes of children. Ventilation rate and duration. If you want to look at the chart on 903, it's a pretty good chart there. Puberty, once they've hit puberty, we really say it's the adult rate, so 10 to 12 per minute. If they are less under the age of puberty, then it's roughly 12 to 20 per minute. Closer to 20 the younger you get. And then a ventilation duration of about 1 second, just enough to see their chest begin to rise. Another way of performing some oxygenation here. She's got her bag valve mask ready to go in case she needs to use it. So common causes of shock in pediatric patients. There are a variety of things that cause this. It's not common for us to see, but certainly we do run into them. More times than not, they kind of come to the ER on their own. Diarrhea, excessive diarrhea or vomiting, infection, septic shock, trauma from abdominal injuries, blood loss, of course, allergic reactions, poisons, and cardiac events. But cardiac events are very rare. Most kids have very good hearts. So signs or symptoms of shock in our pediatric patient, basically altered mental status, that kind of, they're existing but not aware of their surroundings, respiratory rates up, weak thready pulses, delayed cap refill, falling blood pressure, again that's going to be late. They may be crying but don't have any tears. They may not have had wet diapers recently, pale, cool, clammy skin. So if we're caring on our shock patient, obviously they're just showing us kind of the picture of this child again, but care for our shock patient, our pediatric shock patient. It's going to include ensuring an open airway, manage any external hemorrhage. So if they're bleeding on the outside, stop the bleeding. If we don't stop the bleeding, the shock just gets worse. High flow O2 and ventilate as needed. Airway is needed, of course. Lay the patient flat, keep them warm, and transport immediately. So really got no different. It was no different than it was for the adult. Hypothermia. Again, kids have a difficult time maintaining a good body heat. So protecting them against hypothermia. It's more critical in the infants, but even smaller children, this can be an issue. They often don't even have the right common sense to keep themselves warm. So, and then not to mention, once you start to get hypothermic, you start to lose more and more of your ability to reason, which may include taking off more clothes. So cover the patient's head and body. Well, how do you do that? Just cover them all up with a sheet like they're dead? No. You can get a towel, a small hospital hand towel basically, and wrap that over the top of their head. You should carry a couple of those on your truck. Towels come in very handy. Keep the patient compartment warm. So crank up the heat. Remember, it's comfortable for them, not for you. Avoid any rough handling. Consult medical control about rewarming. Keep them covered. Get them out of any wet clothing that they may be wearing. So how do you balance the need to examine a hypothermic patient with the need to keep them warm? Well, if you've got the nice warm in the environment that you're in, you can move things, move blankets and whatnot, examine what you need to, and then return the blankets or coverings to that patient until you need to reassess it. So certain pediatric medical emergencies. Okay, respiratory disorders. Respiratory disorders is the most likely cause of cardiac arrest in a child other than trauma. Respiratory disorders is the most common thing that we all obviously deal with. It's the most common cause for call for EMS period is respiratory distress. Respiratory disorders and respiratory problems is the biggest and a major chunk of the pie when it comes to us and responding to kids. So distinguish whether the probable cause is upper versus lower airway. Care for upper airway obstruction is not indicated for lower airway obstruction. So think about that for a moment. Asthma is a lower airway problem. Choking is an upper airway problem. So asthma, we may do oxygenation and some things to help emphasize good oxygenation, whereas with an upper airway obstruction, such as a foreign body, we have to completely change course and we have to do some Heimlich maneuver or back blows chest thrusts. So, and be alert for early signs of respiratory failure when the patients start to become unconscious and their breathing starts to drop way down and we start to see some very prominent signs of shock. We're dealing with respiratory failure. So signs of difficulty in breathing, very similar to those of the adult. We're talking nasal flaring. That's less common in adults, but they're trying to make their airways as big as possible. Retractions are a little more noticeable in most kids. You may even have sternal retractions. The use of abdominal muscles, something called seesaw respiration, where the abdomen pushes out, the chest goes in. The abdomen pushes in, the chest goes out, as opposed to what's normal is all out, all in, all out, all in. Stridor, which is that high-pitched, squealy, harsh sound. We may have audible wheezing, grunting, where they're trying to keep their airways open. Respiratory rate above the norm of 40, 50, 60. Altered mental status, slowing or irregular respiratory pattern, cyanosis, decreased muscle tone, poor peripheral perfusion, and a decreased heart rate. Obviously, the second slide here is showing us more signs of approaching respiratory failure. So helping to differentiate between upper versus lower, upper airway disorders affect the mouth, throat, and larynx. And foreign body obstructions are common, as well as trauma, swelling, and that swelling can be either from burns or infections. There are a couple of infections that are very common for kids that cause some swelling up there, such as croup and epiglottitis. Commonly identified by difficulty breathing, stridor, or difficulty speaking. So now difficulty breathing is kind of a one-size-fits-all, but the stridor and the difficulty speaking are usually pretty good indicator we're dealing with upper. Whereas we talk about lower, this affects the small and large bronchioles, the alveoli, the linings of those. Asthma, pneumonia, and other respiratory infections are more common for these, and these are more commonly identified by difficulty breathing, again, one size fits all, but a wheezing lung sounds. You may have audible wheezing, but it's not stridor. So croup. croup, they usually have a mild fever and a little bit of a sore throat during the daytime. They have a loud seal bark cough, difficulty breathing, they're restless, pale, and cyanotic. We are fixing to enter the, with it now being mid-November, fixing to enter the significant time zone or time period in which we see croup take off like a rocket. This is typical in children from 6 months to 4 years, and a lot of times is a major problem at night. So they tend to get a little bit more constricted, as opposed to epiglottitis, which is a sudden onset. So croup, they were sick for a few days. Epiglottitis, they may have went to bed fine, woke up in the middle of the night. They have very painful swallowing. They're usually drooling. They have tripod position with their head hanging over. Usually a high fever. They usually sit very still because it's very irritating for anything to touch their epiglottis. And they appear to be much more ill than they are with croup. This is a fairly common bacterial infection, whereas croup is usually viral. And there are a lot of vaccinations that do a pretty good job of keeping epiglottitis under control. So we don't see it very often. We see many, many more cases of croup than we do epiglottitis. However, epiglottitis is a significant emergency because anything touching the epiglottis can cause it to swell and slam shut. So that's very, very important that we're very careful with those patients and their any airway things that we may do with them. So remember, painful swallowing, sudden high fever, tripod position, very ill looking, typically epiglottitis. Seal bark cough, been sick for a while, maybe a little hoarse, maybe a little short of breath. That's more likely to be croup. Either one, place them in a position of comfort, provide high flow O2 or oxygen as necessary. If at all possible, humidified oxygen is appropriate and helpful for these patients, but not everybody has the abilities to humidify. Cool night air. If you have to stand outside for a moment in the cool to allow the ambulance to be ready, that's not necessarily a bad thing. It's usually very helpful, particularly for the croup patient. It just kind of helps soothe those irritated tissues. Not as much of a help with the epiglottitis patient, but it still may. If you're unsure, and you think, well, I'm not sure if it's epiglottitis or croup, do not take a temperature by mouth. Do one via either, usually under the arm is the best way to go, or with the, if you have a one that does the forehead scanner, that works well too. So keep things out of their mouth if you're not sure, particularly epiglottitis. Fever. Children constantly have fevers. The younger they are, they're dealing with something, they're teething, they got some little infection. As they're building up an immune system, they've got a fever. The older they get, the less likely they are to have one. So if the child is hot and they're running a fever, remove their clothing. If it's very high, consider covering them with a towel soaked in just lukewarm or tepid water. Not hot, or I'm sorry, not cold. Cold water can be too much of a shock to the system. Monitor for shivering. If they start to shiver, then you need to remove that cooling measure. Follow any protocols for any water or ice chips. In many cases, they're going to say no, not until we assess them. Do not submerge them in cold water. There's something referred to as febrile seizures, in which kids will have a seizure related to an illness and a fever that they spiked. And a febrile seizure, the most common place I've dealt with kids with febrile seizures is they're sopping wet because they were in the bathtub or the pool, and they got too cold too quick. It was too much of a shock and change for their system, and bam, threw them into a seizure. So with fevers in most cases are fairly benign, not a lot to be terribly concerned with. Do not submerge them in cold water. A lot of parents get freaked out, particularly first-time parents. Oh, my child has a 104-degree temperature. I better throw some ice cubes in the tub and run some cold water and get them cooled off. No. Also, do not use rubbing alcohol. Meningitis is a potentially life-threatening illness and infection to the linings around the brain and the spinal cord. Remember the meninges, the dura mater, arachnoid layer, and the pia mater. Can be caused by a number of things. Bacterial is the worst, but bacterial or viral are commonly seen in ages 1 month to 5 years. However, not completely unmentionable in the adolescent age group. So if we're suspect of meningitis, they will typically present with a high fever, a stiff neck, that's the key right there, stiff neck, sensitivity to light. And they're usually a little bit lethargic and irritable, complaining of a headache. Infants will have some bulging of their fontanelle potentially, painful movement, and they don't want to be touched. They can have seizures, and they can have rashes, particularly a rash is usually indicative of a bacterial meningitis, which is the worst. Monitoring ABCs, high flow O2 airways as necessary, ventilations as necessary. Potentially you may have to do CPR. Be alert for seizures and rapid transport. Diarrhea and vomiting, incredibly common. When we're dealing with diarrhea and vomiting, so many different things that can cause this. Sometimes it's just simply growing pains, teething and whatnot. So excessive diarrhea and vomiting, these are things that can lead to shock, so we have to be concerned with that. Good thing to ask parents is how many diaper changes have we had today or the last couple days compared to normal? And if they've had maybe 2 or 3 days ago they had more than normal, and now today they've had 0 diaper changes or 1 diaper change, that's a good indication that they maybe had a lot of diarrhea a couple days ago, but now they've tapped out. Their system has been shocked of all of its extra waters, and they just don't have it to put out anymore. So transport relatively quickly in cases of signs of shock. In most cases, diarrhea and vomiting, not a big deal. Nice, easy trip to the hospital. Seizures. If we're dealing with seizures just like that of adult, we need to be careful to protect the patient, maintain an open airway for them. Do not put an oral airway in them. If you have a right-sized nasal, you could consider that. Otherwise, simply head tilt, chin lift, or jaw thrust as appropriate. Do not put anything in their mouth. Yes, they're small, but they are strong when they're having a seizure. I know of a situation in which an 8-year-old girl bit through 3 fingers of a giant, or not giant, but of a large grown man when he put his fingers in her mouth to try to keep her from swallowing her tongue. She had a seizure and bit right through him. So be alert for vomiting. That, of course, comes along with seizures and not being able to control your own airway. If necessary, turn them onto their side, provide oxygen, and transport. In most cases, the seizure ends rather quickly. It's a rather short period of time, and we can get them transported fairly quickly. Things to ask about seizures: ask about histories of prior seizures. Was this, if they have a history of that, how was this compared to their normal seizure patterns? Any recent fevers, and have they been taking their medication as they're supposed to be? So, altered mental status. You can have kids that are diabetics and hypoglycemic just as easily as you can adults. A little more common in adults, but it certainly happens in kids. Be alert for any mechanism of injury. Are they truly sick, or did they get hurt? And now they have a bleed in their brain, or they're bleeding in their abdomen. Be alert for the signs and symptoms of shock. Evidence of poisoning. Kids like to get into stuff. Kids are curious. Kids are out looking for, what can I do now? What can I taste? Oh, that looks like candy. I'm going to put that in my mouth. I remember when I was in what we called junior high at the time, the movie Ghostbusters came out, and High C Fruit Punch, or High C Punch, or whatever, created a flavor called ectoplasm, which was kind of like getting slimed on Ghostbusters, and it was in kind of a tip of the hat to the Ghostbusters. But it looked identical to green antifreeze. I don't think it lasted terribly long, and I think that there was significant people raised some objections to, this looks exactly like antifreeze, and kids could easily confuse it. So history is going to be important here. Try to get history from anybody, from the school nurse, from bystanders, whatnot, parents, of course. Try to figure out, are we dealing with a poisoning, or a seizure, or a diabetic, or an injury? So again, we're maintaining airways, oxygenation, ventilation. CPR is necessary. Treat for shock. Poisoning. Contact the Poison Control Center. Poison Control Center, there's national numbers, there's local poisoning control centers, or poison control centers. But having whoever your routine poison control center is on hand, having that number available can be very helpful. Also maintaining contact with the local hospital. Try to attempt to figure out what the poison substance was, and if at all possible, how much, over how long, so on and so forth. Do not consider activated charcoal not within your scope. Provide oxygen transport, and then continue to monitor responsiveness. Be ready for vomiting. It's very possible they could vomit. So poisoning can be a big issue. Aspirin overdose. So aspirin, they're usually hyperventilating, vomiting, sweating, hot. They're very acidic. Sometimes even throw into seizures. Acetaminophen poisoning, a lot of times Tylenol poisoning, they may not have any symptoms at all. When people try to kill themselves with Tylenol, they don't really realize that Tylenol doesn't kill you today or tomorrow. It kills you in 2 months down the road when your liver dies, because the toxic effects of Tylenol destroy your liver. So it may not even appear that they even have anything going on. Things like lead poisoning, iron poisoning, so we've got heavy metal poisonings, muscle cramps, headaches, weaknesses, can have diarrhea, bloody vomiting, petroleum products. Usually the biggest key to those is that distinctive odor that comes from any petroleum products. Remember, monitor your patients closely. Ensure their airway, suctioning as necessary, usually rapid transport. Care for the unresponsive poisoning patient. Of course, be concerned with artificial ventilation. Rule out trauma. If you can't rule out trauma, consider immobilizing that patient. Things happen. Kids don't always tell the whole truth and the whole story. Something may have happened nobody was even aware of. Drowning. So when we're dealing with drowning patients, of course, we've talked about drownings for the adults. There have been kids submerged in cold water drownings that they list in the book for 30 minutes, in some cases even up to 45 minutes, closer to an hour in cold water submersions. So be optimistic when it comes to these. Obviously, you got to do your assessment, maintaining ventilation, suction as necessary, airway adjuncts, spinal immobilization. If you don't know, you spinal immobilize. Hypothermia, get them out of the wet, cold clothes, get them warmed up, warm up the back of the squad, get them covered up. If there's a possibility that ingestion of any substances was involved, consider that as well, particularly in the adolescent population where they're now starting to experiment with drugs and alcohol, got to have some consideration for that. And then be aware that there's a possibility of secondary drowning syndrome, which occasionally will get called on a drowning. Somebody was submerged and within a minute or two was found by their caregivers or friends or whatever. They're pulled up and maybe they gave them a couple of breaths and they kind of came back and they're just fine. When you get there, there is a couple of there's certain cases and times in which that patient actually will deteriorate later because of some of the effects from the water that they may have inhaled or ingested. So anybody who was a drowning gets a transport. SIDS, or sudden infant death syndrome. SIDS is generally what we refer to as a diagnosis of exclusion, meaning that in many cases we simply don't know what causes it, and when we've ruled out all the other causes and it has some of the typical characteristics, it gets labeled SIDS. Treat them as any regular cardiac or respiratory arrest. Resuscitate them unless there is rigor mortis. If that patient has rigor mortis, that's a late sign of death, and there's no amount of CPR that's going to save this child. Be certain that parents receive emotional support. This is going to be devastating to really everyone involved. There's a SIDS video. All right, pediatric trauma. So pediatric injury patterns. During motor vehicle collisions, if they're unrestrained, suspect head and neck. If they're restrained, expect abdominal and lower spinal injuries. If they're struck by vehicles, expect there to be head, abdominal, possibility of lower extremity injuries. You got to think about this. If you think about a full-size person and a small child, or an adult and a small child, both being struck by the same vehicle, what typically happens? If we say it's a full-size car, let's say a full-size car strikes an adult in a crosswalk and strikes a 5-year-old in a crosswalk. Well, if the adult is hit by this full-size sedan, it hits him in the knee, so it probably causes lower extremity injuries, and then usually the adult kind of flops forward onto the hood. The other interesting thing is when an adult recognizes that they have the potential to be injured or in this collision, they usually look away. It's very common for an adult to look away, and a child, on the other hand, will continue to look straight at it. But so with this adult, hit the knee, flop forward on the hood, so we can have some head, neck, spine, arm injuries. With a 5-year-old, the 5-year-old gets hit in the chest, so there's the possibility of chest, the possibility of head from their head hitting the grill or the front of the car, and then the child goes down and under the vehicle, whereas in most cases an adult goes up and over the vehicle. So the pattern changes. So here we're looking at pediatric injury patterns again. So to review, examining the head, examine the eyes, the neck. All of this is really very similar to what we discussed before. Chest, remember the contents of the thorax. I'm going to spend time on that. Auscultate for breath sounds. Actually, it's listing a little low for that breath sound. Examine the abdomen, reminder of the quadrants. Examine the pelvis, the arms, the legs. Don't forget the back and spine. So immobilizing a child with a KED. This is a good thing. Immobilizing a child with KED. If you don't have a pediatric immobilization device, which that's the preferred, that you have a pediatric sized backboard, but if you don't have it, you can use a KED or a vest style extrication device. Note what they've done here. The child's got the C collar on. Now appropriately, for demonstrative purposes, they don't have anybody holding her head, but In reality, yes, somebody should be holding her head. So they've got a C-collar on her. They're going to roll that the sides of the head immobilizer up, and they actually have tucked it in a bit there. If you notice, if they didn't kind of tuck the sides of that in, one or two little slats in, it would have actually came around and covered part of her face. They were able to use regular head straps there. And then using the abdomen portion and the lower chest portion of this, they are able to wrap it again around her abdomen and her upper legs. And they've chosen to tape it down here. It works almost as well if you take the straps and you wrap it around all the way around. So if you would pull it, instead of just like in the adult where we pull it from the right side to the left side, click it in the buckle and pull it tight, you actually pull it from the right side around the left side all the way around the back and up again over to the left side and click it in the buckle and pull it tight. That usually works just as well. Otherwise, yes, tape works here too. And they also have had to roll in the sides on that. Otherwise, it would have overlapped too much. Before we move on to burns, I want to draw your attention to page 919 in your text. You have a chart there. It talks about high-risk mechanism of injury and injury patterns for children. I'll just draw your attention to the mechanisms. You can read about the types of injuries that you may typically deal with. Falls over the age of 15, we're basically going to say over 20 feet or 2 stories. Under the age of 15, any fall greater than 10 feet or 2 to 3 times the child's height. And I think that that's pretty, that 2 to 3 times a person's height is a pretty good all-around, excuse me, all-around rule of thumb to use there, because in a, we'll say, 6 foot tall person, 3 times that is roughly 18 feet. So it's not a bad rule to just keep in mind all the time. Seriousness can depend on the height of the fall, surface in which they fell onto. Did they fall into a bush or they fall onto concrete? And the child's age. So, remember, a child rolling off a couch, an infant rolling off a couch 2 to 3 to 4 feet can have a significant head injury. Improperly restrained passenger. The car seat wasn't in right. They weren't wearing a seat belt. They didn't have their booster seat. Child struck by a deployed airbag. Remember, children and front seat airbags are not typically compatible. A cyclist or a pedestrian hit by a vehicle going greater than 20 miles an hour. Any of those have the potential for significant risk. All right, so to move on to burns. Burns are common in the pediatric population. They're not, they haven't learned yet that pretty blue light on the stove is actually a flame, and it's hot, and it will cause you to have a lot of pain. They just see it's pretty. So, pediatric patients oftentimes very quickly become candidates for burn centers because of their compact nature. So remember to cover burns with non-adherent sterile dressings. If it's a smaller burn, you can moisten the dressing with some sterile water. But if it is a larger scale burn, try not to do too much sterile water in order to prevent them from becoming hypothermic. Airway suctioning, mobilization as necessary, and rapid transport. Calling for ALS, of course, is very appropriate. We also like high flow O2, particularly if we consider that there may be airway involvement. So we can cover these kids up with a nice sterile burn sheet. If you don't have a sterile burn sheet, a nice clean sheet is better than nothing. We just are cautious with moist dressings on a pediatric patient because it's so easy to make them hypothermic. So a lot of times we are concerned, well, it's going to stick. This might stick to them. Well, if it sticks to them, they can deal with that. They can get that slowly work on debriding that out of the wound. But once we get them hypothermic, it can be very difficult for us to get them back to where we need them. Just a reminder on assessing the body surface area that's been affected. Burns, remember here's our rule of 9s for the adult. Everything's really pretty much a 9, right? So the whole head's 9, each arm is 9, or 4.5 per front and back. The chest is 9, the abdomen is 9, the upper back is 9, the lower back is 9. The front of each leg is 9, the back of each leg is 9. Genitals are 1. Well, when we go to the child, we redistribute some of that. We redistribute some from the legs, so we steal, essentially steal 4 from each leg, and give that back to the head. So it becomes 18 for the head, 7 for the front and back of each leg. And then with the infant, it's the same. So it's still 18 for the head, and then 4.5 for the front of each arm, and 7 for the front and back of each leg. All right, cases of child abuse and neglect. Probably some of the most disgusting calls you'll ever have to deal with. But here's a case of child abuse in which a child was scalded by being dipped in hot water. So signs of possible physical and sexual abuse: slap marks, bruises, abrasions, lacerations, incisions, broken bones, head injuries, abdominal injuries, bite marks, burn marks. Now, each and every one of these can potentially have a very valid accidental excuse. So we have to be cautious. We have to look for patterns. We have to look for other things to go along with it. You know, a slap mark, if it's the size of a small child's hand, another small child's hand, maybe it was kids playing around, kids being kids. Bruises and abrasions. I think most of us can remember back when we were kids, we ran around probably with skinned up knees all the time, or bruises on our knees. Where the bruises and abrasions kind of come into place is they're in odd areas. The back of the thigh. We don't typically have abrasions and bruises on the backs of our thighs or on our lower back. That's not common. There still can be a justification or a valid reason why it happens, just not as common. Kids fall, they break bones, they get hurt, they bite each other at daycare, they bite each other at school, whatever. They're curious and they get burned. But we have to look for the oddball things, such as if you had burned feet. You have a child with what we refer to as stocking burns, where it looks like they have socks on, but it's burns. A kid doesn't jump both feet into a hot bathtub. They're going to stick one foot into a hot bathtub and say, "Oh, hell no," and jump out of there. Or a ring around the butt. So a lot of times we'll have ring burns around their buttocks and their upper thighs, but in the very middle of this ring, there's no burn. And that comes from hot bathtubs with cooler than water temperature porcelain on the bottom. The kid gets pushed into this bathtub in their butt, but part of their butt touches the cold bottom of the cooler, not necessarily cold, but the cooler surface of the bathtub down below, and that doesn't tend to get burned. So possible indicators that the adult is an abuser: they have inappropriate concern about their child. Sometimes it's way over the top, but in many cases it's kind of ho-hum. They have trouble controlling their anger. They maybe are even lashing out in your presence. They may be in depression, signs of alcohol or drug abuse. Maybe the adult is suicidal. Many adult abusers were abused as kids. So care for abuse patients, dress and provide other appropriate care, preserve evidence as best as possible on transport. You're going to care for this kid just like you would really any other kid with a type of injury. The key difference here is noting the things that you saw, you heard, you smelled, you whatever, the evidence that you collected. You are going to do no accusations during this. It is not our job to investigate and arrest people for abusing their children. It is our job to take care of that child in the case in which they have been abused. Now, by us noting and being very good at documenting and making sure that the whole story is told and doing the very best job we can to show compassion and care for the child, that's what's going to allow the law enforcement to then get in there and deal with the situation, to get child and family services in there to investigate this. But by us starting to make accusations, get people up on edge, and as the potential for us to then have to deal with somebody that says, oh, you're not taking my kid now. Nope, you're not taking my kid. When we really need, what we need to do is get this kid to a safe place and take care of their illnesses and injuries. Let us do that, and that will allow the other professions to do what they need to do. So your role, gather as much information as possible. Talk with the child separately. Plainly and clearly report everything to the medical staff as far as your findings and suspicions. Use the terms suspected and possible even when talking with your partner, hospital staff, police, and superiors, and then contact the appropriate abuse reporting hotlines. You generally have 24 hours to make a verbal report and 48 hours to make a written report. If law enforcement's already been involved, usually they're the ones that take care of getting the report made. You still may be asked to do some additional documentation. So what should your concern if the parent is in a possible abuse case reveals suicidal ideas? This now becomes a multiple faceted call. We need to get extra help there. We need more, we need law enforcement if they're not already there. We need another truck to deal with the psychological or the behavioral emergency that's just revealed itself. We may need to work on getting this child out of here as quickly as possible. Hopefully law enforcement gets there very soon. If we leave this child in this situation with a suicidal adult, there's a very good chance that something bad could happen to this child. So infants and children with special challenges, we're going to touch on this a little bit more in a later chapter in this section, but we'll kind of brush on it right now. There's a lot of common special challenges. In this day and age, there's a lot of people on home care that typically just decades ago would have been institutionalized, whether it was in a nursing home or hospital or whatever. Premature infants who have lung disease, heart disease, neurologic issues, chronic diseases, birth defects, cerebral palsy, so on and so forth, birth trauma. For just an example, this isn't really a child situation, but remember, or if you're not aware of this, just 2 to 3 decades ago, about 3 decades ago, I guess, 3 to 4 decades ago, a woman gave birth, was in a hospital for 5 to 7 days. And this day and age, women may be lucky to get their full 24 hours before they're discharged. So with the evolution of medicine, the push is to not keep people in hospitals for a long time. So a lot of these people are going home. You may have tracheostomy tubes with the potential issues with obstruction, bleeding from around the tube, air leakage from around the tube, infection becomes dislodged. There's an example, and it's kind of difficult to see, maybe a little easier if you look at page 925's got a kid on a ventilator. 926, you can see the kid with a tracheostomy tube there. but those tubes bypass the mouth and then allow the child to be ventilated through a hole and generally an appliance in their throat. So really our emergency care, here's that picture, our emergency care is going to involve, there's artificial home ventilator, it's going to involve us maintaining ABCs. We may need to ventilate this child. If the ventilator's going haywire, we don't know how to deal with the ventilator. Take them off the ventilator, hook up the bag valve mask, and you know how to ventilate a patient with a bag valve mask. Keep them in a position of comfort. If you got bleeding from around a trach, try to do some gentle pressure around there to control that. Suctioning, suction the patient. In some cases, if you're having a difficult time with the tracheostomy, you may consider putting a thumb over the tracheostomy and trying to ventilate them through their mouth and nose with a mask. And in some cases, you're able to do that. A lot of times, patients on home artificial ventilators, the biggest problem we'll deal with them is that they may be having a ventilator issue. We have a ventilator. It's called a bag valve mask, so just use it. God, that's a terrible picture because that's not a central intravenous line. That's actually a gastrostomy tube. So ignore this central intravenous line. But the gastrostomy tube and gastric feeding, this child is being fed through this tube in their belly wall, and that either dumps directly in their stomach or it may dump into their intestines. A lot of times these children are very sensitive to changes in their glucose levels. Sometimes they also have problems with aspirating food. They'll get some of this to kind of back up, and it backs up and gets into their lungs, and they develop some pneumonias. The biggest thing that I guess I've dealt with kids with G-tubes and G-buttons, which is one that doesn't have a tube on the outside, it's just a cap, is kids like to pull them out. And so you'll end up taking a kid into the hospital for they pulled out their G-tube and needs to be replaced. So, generally, try to transport the child with their head upward to help reduce that risk of aspiration. Central intravenous lines, yeah, there's the G-tube stuff. Central intravenous lines usually are placed high in their chest, not in their abdomen, or maybe in their arms. But the biggest problems that we tend to see there is infection around them, or they just stop functioning appropriately. If you've got bleeding around them, a little gentle pressure at the site and transport. These are usually not a big deal. Shunts, patients with shunts, maintain an open airway. So you're going to need to keep their head tilt chin lift as necessary. Ventilate with a pocket mask or BVM if they're having problems with breathing. A lot of times this shunt is a drainage that runs out of their brain, out of their skull, into their abdomen. As the kid grows, they outgrow their shunt, or sometimes it becomes blocked, causes an increase in intracranial pressure, and then therefore causes some altered mental status. And with that, it can cause some problems with ventilation and so on and so forth. With these patients, it may be also helpful to transport them with their head elevated somewhat. So briefly, EMT and pediatric emergencies. Pediatric calls are very stressful to us in EMS. They're stressful for the simple fact that we don't deal with kids on a regular basis. And even if we did, kids aren't supposed to be sick. We expect people that are elderly to be sick, but kids that are sick, that's very hard on us. A lot of us have our own children. We may be very anxious about dealing with children because we're not comfortable or don't deal with them every day. And then most serious stresses or very sick or injured or abused child or a child who dies, those are the ones that tend to stay with us. Those are the ones that really, really pull at our heartstrings. So it's very stressful to deal with pediatric patients. So to deal with stress, of course, going way back to basically week 1 when we talked about the well-being of EMT, learn about kids, take more classes on kids, talk with other EMTs, talk with service counselors, go to CISDs or CISMs when you get a chance. If it's really bothering you, talk to a professional. Talk to a psychiatric, a psychiatrist or a psychologist. And then practice. Practice your pediatric skills. Learn more. The more you can learn about kids, the more you can be comfortable with those pediatric skills, the easier it's going to be for you. So in review, assessment and treatment from children is often slightly different than that of adults. A lot of it is the same though. There's some significant differences anatomically and psychosocially that we deal with. Assessment and treatment procedures must take into account specific differences, such as padding beneath the shoulders. As an EMT, you got to learn the differences to enable you to better serve the population. Pediatric patients present unique anatomy and physiology. Yeah, we talked about that. Caregiver interaction sets the tone for the scene management. The parent is going nuts, the child is going to go nuts. Pediatric assessment triangle allows us a very quick tool to determine the severity of our patient. Proper pediatric assessment takes into account the differences in anatomy and psychosocial development. Airway and breathing maintenance, shock care, prevention of hypothermia are universal care point for important in pediatric care. Shock can be very subtle in children, and recognition of respiratory failure in children, and differentiating between upper and lower airway disorders is critical. Different anatomy leads to slightly different patterns of trauma in patients in the pediatric versus the adult. Be alert for findings of potential abuse. Treat the medical issues, then document. Many children have special health care needs, and most caregivers are trained to handle emergencies and can be an important resource for you. The mom and dad are dealing with this child all the time. They probably know much more about that ventilator or that G-tube than you ever will. Critical incident stress management is critical. So questions to consider. How do you plan to approach your first pediatric call? You need to make sure that you're comfortable and hopefully working as a team. How do you determine the appropriate mental status for a child? A lot of times it's asking the parents and the caregiver. Give certain situations, how would you involve the parent or the caregiver in the treatment? In almost all situations, as long as you have a parent that's keeping it together, they're one of your best tools you can use. You're called to the home of a 3-year-old with a low-grade fever for all day and is now drooling. As you enter the child's bedroom, you hear what you think is a seal-like bark. What do you suspect is wrong with this patient, and how will you or your partner treat this patient, or you and your partner, and handle the situation? Let's go back. 3-year-old child, low-grade fever, all day, drooling, and seal-like bark. Well, this sounds like some sort of a respiratory infection, probably an upper respiratory infection. So we have to stop and look at it. This is a younger child, lower grade, been going on for a while, seal-like bark and cough. Those are all kind of go together with the profile of a child with croup. Drooling could potentially throw you off here as thinking, oh, it's epiglottitis, but children with croup also can have drooling as well. Most of the signs point towards croup, so that would be our appropriate decision. Some humidified oxygen, if at all possible, or exposure to some cool, moist air, if we're able to do that. Maintaining an airway, we may need to do a little suctioning, and then monitoring the patient transported in a